Excellent. السلام عليكم ورحمة الله وبركاته. Good evening everyone. كل عام وانتم بخير. تقبل الله منا ومنكم صالح الأعمال. My name is Osama Al-Mqbil. I'm a cardiologist and heart failure specialist, and I'm joined today with really esteemed speakers, Dr. Ismail Raslan, Dr. Ibrahim Jalidan. Basically, we're going to continue what we left before Ramadan. We started with heart failure and reduced ejection fraction, what the guidelines tells us, what's beyond the guidelines, and what's in the horizon. And today we're going to expand the horizons for heart failure with mildly reduced and heart failure with preserved ejection fraction. And it's going to be 1 hour, 20 minutes session full of really a lot of science and engagement, inshallah. And if you have any question, you can type it in the Q&A. And regarding some housekeeping issues, if you have any question about CME, please don't ask. Everyone register with their email and join the webinar today. It's going to be, inshallah, getting that 2 hour CME automatically without any, you don't have to really give us anything. And for those who missed the webinar, it will be recorded and posted at the Saudi Heart website and YouTube. So for those who couldn't attend the first and this webinar, it should be available for them there. So I'm really, really excited, honestly, to chair this session because this is an area where probably you guys gonna hear a lot about new things every day. It has been overlooked for years, and now I think everyone is interested in this area. So it's going to be really exciting. So I'm going to start the first talk. It's going to be about understanding the terminology, definition, burden, the challenges, the overlap in patients with mildly reduced and preserved ejection fraction. It's going to be presented by my dear friend and colleague, Dr. Ismail Raslan. He is a heart failure specialist, assistant professor at King Saud University. He's the lead of advanced heart failure heart function unit in our hospital. And he's going to present to us everything about definition and challenges. Dr. Ismail, floor is yours.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank my dear colleague, Dr. Osama Al-Mukbil, on this kind introduction. And it's my genuine delight to be with all of you here today to talk about this topic, along with my colleague and friend, Dr. Ibrahim Al-Jalidan. So, we're continuing with the saga of heart failure, as we've previously discussed in heart failure induced ejection fraction. When it comes to heart failure with mild, reduced, and preserved ejection fraction. Now, to start off, why does this matter? Because as we've all mentioned before, heart failure is all around us. And one way or another, directly or indirectly, we are going to be affected by heart failure. Now, the global prevalence is about 1 to 3%. But when you look at HFpEF, it ranges from 15 to 50% and mild reduced about 15 to 25%. And once a diagnosis is made, the mortality is somewhere about 50% in 5 years. And you can appreciate that the margin of prevalence is very large, and that really depicts the difficulty in identification, but also the difficulty in diagnosis and the confounding factors that comes with these diagnoses. If you survey a specific population, you're more likely to find HFpEF than a specific population, and we'll get to that shortly. One thing is clear, that the older the patient population is, the more likely they are to develop heart failure. And also, there are disparities in care. So depending on geographical locations, ethnicities, skin color, these are all coming to play when it comes to incidence and prevalence of heart failure. Now, to the same point as we've mentioned before, these cutoffs are important to know, but what you would come to realize later on is this is not completely written in stone. It's one of the pieces of this so-called puzzle that we have for heart failure and preserved and mildly reduced ejection fraction. But from a number standpoint, anything that's more than 50, as you know, is HFpEF, and anything that is less than 40 is heart failure with reduced ejection fraction, and mildly reduced is somewhere in the middle. And you can appreciate what are the determinants or what are the things that would increase your likelihood of having HFpEF, such as what you find under the orange field and things that are likely to be seen more in the HFrEF population. And then there is this mish of things in between where are you to the first or are you to the second? And these differentiations are important because phenotypically they behave differently, but also, as you're going to hear from my colleague, Dr. Ibrahim, the management and treatments are also dependent on these arbitrary numbers of ejection fraction. You have to keep in mind that there are temporal trends that take place, especially in the HFpEF population. And a lot of these times, you do not identify a problem until these patients come exercising. So, one of the complaints you get in your clinic is when I start walking or when I exert myself is when I start developing symptoms. And that's primarily what we call exercise-induced left atrial hypertension. And if that is left for a prolonged amount of time, that really affects you to develop resting left atrial hypertension, and thereon after you would have right-sided heart failure, which is the extension that takes place. And at that point, you've already passed the line in what we call the phenotypic spectrum of a diagnosis of heart failure preserved ejection fraction. The clinical presentation of a HFpEF or a HFmrEF really depends on when do you capture your patient. And if you're waiting until your patient gets hospitalized to make a diagnosis, I'm sorry to tell you, but you've already missed the boat. And the signs and symptoms usually precede. And as we mentioned, what you're looking for is these ambulatory symptoms, these exercise limitations that you have. And that is really what helps the diagnosis, because the earlier we identify, the more likely that we might have elements that we can intervene on our patients to improve not only their symptoms, but also their outcomes. As part of your assessment, you need to understand what your patient's ejection fraction is, and that is from the guidelines, but also you need to understand what is happening to my patient throughout time. So for example, a patient who is a HFrEF later on improves his ejection fraction, or a patient who's a HFpEF starts dropping their ejection fraction over time, or somebody who was a HFmrEF who stayed where they are. So your role really is to understand where am I at point A, but what is happening in this relationship that we are building with our patients as time goes by. Now, as we mentioned, it is a spectrum, and it's not only one disease, but multiple overlapping phenotypes, but they all converge into one phenotypic and pathophysiological element, which is elevated filling pressures, either at exercise or at rest. And these phenotypes might represent distinct entities, or it might present distinct stages. So when you're looking at a graph, and that's what we started off when we showed you the prevalence with this wide confidence interval for these patients, depends on where you are and who the patient is. But the most common effectors for HFpEF, for example, is hypertension. The older the patient is, the more likely to get it, underlying coronary artery disease, female gender, chronotropic incompetence, obesity, and many other reasons that could take into place. And this is one of the things that makes the diagnosis difficult, but also makes the suspicion also difficult, because it's not as simple as a HFrEF where, i.e., you went in, you put an echo, and you made a diagnosis, or somebody who had an MI and thereafter dropped their ejection fraction. I really like this paper. Essentially, what they looked into is they looked into phenotypes from the TopCat trial into three main phenotypes. But essentially, within a diagnosis of a HFpEF, people behave differently, and you can tell phenotype 1 and 2 and 3 behave differently based on certain characteristics that you appreciate over here. So again, finding the diagnosis, making the diagnosis, and how does people respond to the diagnosis is another layer of complexity that you need to take into account in these patients. The other issue is when a diagnosis or when a patient is hospitalized for heart failure, your outcomes or your 5-year survival is affected pretty much similarly to a HFrEF. So it's not as benign as one might think it is. And these are all elements that points us and supports us trying to identify these person early and intervene early. Again, this is also from the ESC guidelines where you're looking for somebody who has suspicion, risk factors, or signs and symptoms, or an abnormal ECG, a BMP, looking for signs of congestion, followed by an echocardiogram, and that determines your etiology, but also determines your treatment, as you will hear from my colleague, Dr. Ibrahim. So the journey, so to speak, in a diagnosis of heart failure preserved ejection fraction or mild reduced is one of two things. The patient is going to come to your clinic primarily either complaining of dyspnea or they're complaining of edema. And your main objective is number one, to assess, is this related to something else? So for example, let's say somebody comes in with exertional shortness of breath and they're 35 female with severe iron deficiency anemia, your pathway is completely different. Or let's say somebody comes in with severe bilateral lower limb edema, but creatinine that is high and he has nephrotic range proteinuria, that is also another entity altogether, and the management is different. So your role at this point is to put on your investigator hat and really tackle this as an internal medicine, multidisciplinary approach to make sure that you have not missed a non-cardiac source. Because if you're focused on a cardiac source and you missed a non-cardiac source, you might have wasted or lost some very precious time that could have changed trajectory and management. You apply a universal definition, you assess for heart failure mimickers, and basically you assess the likelihood of a diagnosis in these patients, and then you make a diagnosis of HFpEF. So as we've mentioned before, you're looking for the signs of symptoms for these patients in a HFpEF and EF that is more than 50, but also you want to make sure that there are signs of congestion in these patients, so an elevated pro-BNP, or you have evidence of pulmonary edema or pulmonary congestion. Take into account that when you're looking at the BNP, it's not the only parameter we're looking for, because a lot of these patients are obese patients, and in these obese patients with higher BMIs, the BNP or the pro-BNP can artificially be lower than it actually is. And that brings on layers of diagnostic uncertainties. As we mentioned, the symptoms can be very non-specific. Dyspnea, fatigue, exercise intolerance, and these are things we hear all around us. You can develop some of these symptoms if you had a really hard day at work. So it's your role to actually decide which one of these symptoms are the trigger, or at least just raises your attention to start investigating further about heart failure in these patients. We've mentioned that natriuretic peptides in about 1/3 of the patients might actually be normal. When it comes to echocardiography, the diastolic parameters can be insensitive and maybe abnormal only on exercise. So that's another layer that you need to take into account. And the gold standard remains invasive hemodynamics. So a pulmonary wedge pressure that's more than 15 at rest or more than 25 with exercise, but that's something that is not widely available in your patient population. So the result is HFpEF remains under-recognized in these patients' populations. And that takes us down to diagnostic scores and how best can they be utilized. So the main two that we utilize is the H2FAF score and the HFA-PEF score, so American and European scores. And if you look at the H2FpEF score, it's much more easier. You can do it on the bedside where you're looking for overweight, you're looking for hypertension, atrial fibrillation, pulmonary hypertension, older age, and elevated filling pressures. On the other hand, if you look at the HFA score, you're looking at several domains. Some of them are functional and morphological and biomarker related. And that compiles major criterias and minor criterias that are outside of the scope for today. But what you have to keep in mind that when you're looking at the H2FEF score, it's, in my opinion, best for frontline screening. It's in unexplained dyspnea. It's simple, it's quick, it's sensitive, but the limitation over here, it does not take biomarkers, and it might also miss inflative diseases. And the validation AUC was 0.84. Now, if you look at the HFA-PEF score, it's best for structural specialized evaluation. It's more comprehensive, it's systemic, it includes pro-BNP and imaging. And the limitation, as you have noticed, that it's complex. And a lot of patients might unfortunately fall into what we call the intermediate score, where more testing is actually needed. So in simplicity, once you've seen your patient and you have somebody who's low probability, then the likelihood of HFpEF in these patients are low. High probability, then you've reached where you want it to be and you would continue. But in the intermediate population, hemodynamic testing is what you would consider. So in another term, if it walks like a HFpEFer, behaves like a HFpEFer, then likely is a HFpEFer, but you need to investigate further. And that is essentially the role of exercise testing in these patients. And you can see only when you exercise your patients is when you start noticing this impressive diastology in these patients. Another thing that you have to keep in mind is the higher the score, the more likely that your patients are going to be hospitalized and the more likely they are to have CV death. So it's important to know where you are and basically where you're going in these patients. And I find these discussions really help engage these patients and bring them back to the table about where you are and what you're trying to accomplish in the journey of diagnosis and management of these patients. So to conclude, heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fractions are not static labels. They are dynamic clinical syndromes that can evolve over time with treatment, progression, or recovery. Ejection fraction alone is not enough. Diagnosis and management require full clinical, structural, and biomarker assessment. Diagnosis remains challenging. Scores can help, but they are imperfect, as we have alluded to. And the future, in my opinion, is phenotype-guided care. Treat the underlying drivers, not just the ejection fraction category. Thank you very much.
All right, thank you so much, Dr. Ismail. That was really fantastic. You really simplify the complexity of the syndrome, and hopefully now we can move on to what's in the horizon about this disease with this syndrome, about any clinical insights, anything in the near future about this really difficult to manage syndrome, as Dr. Ismail mentioned. So this will be presented by Dr. Brahim Jidan. He's a dear friend and colleague. He's a consultant, adult and advanced heart failure, an echocardiographer cardiologist at King Faisal Cardiac Center, National Guard, Jeddah. And he's going to really enlighten us about really what's in the horizon. Dr. Brahim, floor is yours.
طيب السلام عليكم ورحمة الله وبركاته. Sorry, I was looking for the mute button, فجأة disappeared on me. Thank you very much, Dr. Osama, for the introduction. It's always a pleasure to be with you. And thanks, Ismail, for the amazing first lecture that will pave the way for this lecture. And as you mentioned, the complexity in this disease usually make its treatment challenging, and I'm going to try to go slowly into the basics of the clinical trials and what are we doing for the management of this disease from early on, with all the unsuccessful or let's say failure of the trial that we had in the beginning and a lot of disappointment until the recent let's say success that's followed the success of HFrEF over the last 10 years. So those are my disclosure. So what we'll try to go and learn in this lecture was, first, we'll start by understanding the historical changes in pharmacotherapy in HFmrEF and HFpEF. Then we'll go into what is currently in the guideline, what is proven actually at this stage, and we need to start your patient, which is the SGLT2 at this stage. And then we're going to go through what's currently evolving into the evidence with the non-steroidal MRAs, the GLP-1s, and are there any combination strategies? Some mention about IV iron, and not in HFpEF. It's mainly probably in the HFmrEF group. This is a typo from me. Sorry about that. And then integrate new trial data into practical treatment frameworks. Not a guideline yet. The guideline is still lagging behind, I think, at this stage, but something that I think will be useful for day-to-day clinician. So as Dr. Ismail mentioned, heart failure is a challenge. So we know that heart failure with reduced ejection fraction is a challenge with bad mortality, morbidity for the patient. And we can copy and paste the same numbers of heart failure with reduced ejection fraction and apply it to heart failure with mildly reduced ejection fraction and preserved ejection fraction. It's basically the same. So we're having the same burden of the disease, maybe a bit more with the HFpEF right now with the aging population, all the parameter that we're seeing right now is getting more and more in terms of the popularity. We're also carrying the same kind of prognosis, regardless of the current registry that we're looking at. This prognosis gets worse with readmissions. So any readmission usually rise this number to numbers that's really worse than a lot of other fatal disease that we think about, like cancer and etc. And as I said, the prevalence of HFpEF is rising with time, with a lot of other metabolic diseases that will increase the prevalence and will increase the challenge of managing those patients. And the trip to reach where we are right now was a little bit disappointing for science and for heart failure management, starting early on with the ARB management and the ACE inhibitors. So, and we do believe probably, and a lot of people believe that the failure of those trials was because we are probably trying to manage HFpEF and HFmrEF like HFrEF. As Dr. Ismail mentioned, HFpEF by itself have different phenotypes and it's challenging to manage those patients. So the HFrEF population usually manifests as something primarily cardiac in nature. So there is an MI, there is something happened to the cardiac structure itself that's affected the cardiac output, decreasing the perfusion, activating the neurohormonal pathways, etc., etc. In the HFmrEF, HFpEF, it's more likely that there is something else going on. It's the heart. Is it the chicken or the egg? Does the heart follow the metabolic issues, or the metabolic issues follow the heart? I think it's still ongoing and evolving knowledge, but those patients have level of obesity, metabolic syndrome, diabetes, CKD, AFib. So the usual just management that we're doing with the HFrEF did not manifest in a lot of success. So the ARB trials, the ACE inhibitor trial, did not show significant primary endpoint, although some of the trials showed some hospitalization benefit. Then we have the TopCat trial. I'm going to elaborate a little bit more on it, and that was a negative trial. And we had some excitement about the Entresto, the sacubitril valsartan, initially with the HFrEF, but when you applied this data to the HFpEF population, unfortunately, it barely missed the primary endpoint with a lot of analysis, with subgroup analysis, secondary data that's showing promising results. But if we go by the book, if we put it this way, it still was statistically negative in terms of its primary pre-specified analysis. So, and as I mentioned, the TopCat was the one that was really milked out and analyzed a lot, because we could find some hope in those data, because we found differences between the American cohort of the study and the cohort that was done in Russia and Georgia. And the reason is that the people that we were diagnosed in America were behaving like a heart failure patient. Their incidence of heart failure hospitalization were higher. They acted like this. Their BNP level was higher. But when you look at the people in Russia and Georgia, there was a lot of signals about non-compliance to the medication with no significant side effect profile similar to the American population with the spironolactone use. The events of heart failure itself was not as high. The events was low, as if it's a hypertension population. So probably that's why we did not have the data. And when we did analyze it in a way, it showed some benefit in hospitalization. That's why the guideline was putting MRA as a class 2B in managing those patients. And we had the same disappointment with the Paragon heart failure trial. So the sacubitril valsartan, initially when we studied almost more than 4,000 patients, ejection fraction more than 45%, the primary endpoint was barely missed. But when we look at multiple subgroup analysis, we find a lot of positive data in certain population. So we found that in women, for example, there was positive trend toward decreasing hospitalization. The same thing when we have a lower ejection fraction. So the lower your ejection fraction, the more benefit that was pronounced in those population. That's why it was added to the guideline as a class 2B for the HFmrEF population and the HFpEF population. So at that point, if we look at the guide, I will look at the guideline. So you can see that if you compare the American guideline, European guideline, and the Saudi guideline and put it in the right side, and I will mention why the SGLT2 inhibitor is the first one in the class. You can see that they are the one that driving the most benefit, and I will mention why. But you can see that the ARNI, the MRA, the ARB/ACE inhibitor, and beta blocker are all classified as a lower level of evidence in those population. And even in the HFpEF population, actually, they are not involved that much except for the SGLT2 inhibitor. So why that happened? Because of the SGL2 inhibitor breakthrough. So what started with a continuous, unfortunately, failure from almost a couple of decades, started with the success with the Emperor Preserved and Delivered trial. So the Emperor Preserved was the first positive trial that looked at the SGL2 inhibitor, which is empagliflozin, in patients with heart failure and mild reduced and preserved ejection fraction. It was a very large study, and the primary endpoint was cardiovascular death or heart failure hospitalization. Or heart failure hospitalization, and that was positive result by a hazard ratio of 0.79. That's meeting the cutoff of p-value, and that was the first successful trial in that ward. And we know from analyzing the subgroup from the secondary endpoint that the primary benefit came from decreasing of the heart failure hospitalization, which is a significant point for those patients because a lot of the HFpEF, HFmrEF population suffer a lot from the quality of life, the dyspnea, and the repeated hospitalization. And as Dr. Ismail mentioned, that this is a marker of worse prognosis. So slowing down those hospitalization rates is actually very significant. In this trial, there was also slowness of the eGFR slope, which is also we find in other data with the SGLT2 inhibitor with the kidney function, and that was great. There was the trial was positive with both HFmrEF and HFpEF, with some minor attenuation of the result with the HFpEF population. So this was a landmark first positive trial in HFpEF history, ended almost 20 years of therapeutic nihilism and negative data because the benefit was primarily driven by the heart failure hospitalization reduction. Could we concern about the attenuation of the result by increasing the ejection fraction? There was some thought about this, but resolved by the DELIVER trial. So this trial was followed by the dapagliflozin trial. So the DELIVER trial did the same kind of study. So basically, they looked at the patient with heart failure and mildly reduced and preserved ejection fraction. Even they included broader population, so included population with improved ejection fraction. So people who were HFrEF and improved to more than 40%. So it's a wider population. And also the primary endpoint was positive. So you have a hazard ratio of 0.82, so 18% reduction of the combined endpoint of worsening heart failure and cardiovascular death. Primary driven by the worsening heart failure, as seen here in the data, which is similar to the population of the empagliflozin. And there was a secondary endpoint about cardiovascular death and total event, which can always be an evidence generator, but not a clear cutoff mortality benefit. And we did not see any attenuation of the benefit above 60%. So that kind of emphasized on the strong strength of the Emperor data and resolved the concern that we may have by the supra ejection fraction people, and also with the involvement of the improved ejection fraction. And when we look at the pooled analysis, so there was analysis that was done like combine both data of the DELIVER and the Emperor trial, we can see that at this time, they started to have a cardiovascular death and heart failure hospitalization positivity that's consistent across all subgroup with a good hazard ratio of 0.74 with the two medication combined together. When we look at this, at the pool analysis, as I mentioned, we can see that there was a trend numerically for the all-cause mortality, but it crossed the line when it was not statistically significant. It was positive for cardiovascular death by itself, first heart failure hospitalization, and combining both points together. So the mortality signal only emerged when pooling across all 5 trials, a very large population. And that reassured us that the number needed to treat for heart failure hospitalization over 2 years around 28, which is a very good number for heart failure studies and cardiovascular medications. So that opened the door for the next step for this management. So now we're introducing the non-steroidal MRAs. So just to be clear about it, that the only currently proven medication for heart failure therapy in the guideline is the SGLT2 inhibitor. Those medication will probably update the guideline. We're still not in that process yet, and I don't think it's FDA approved in Saudi Arabia. It's FDA approved in the US and the European and the European countries. So the story started with multiple studies. So I'm going to go and walk you through it one by one. So what is non-steroidal MRA? So it's a modified structure, a little bit bulkier and more selective than the spironolactone. So developing this structure, we're hoping to have more cardioselective protection with less side effect profile, less hormonal side effect profile, and theoretically probably less renal dysfunction and renal side effect like the hyperkalemia. So was that the truth or not? We're going to go through the evidence. I'm going to go through multiple trials. So the Fidelo trial, the Figaro trial, the Fidelity, which is analysis of those trials, the Fine Art Heart Failure, and the Confidence trial. So basically, when they started with stage A heart failure, basically. So those are patients with diabetes and CKD. The CKD was evident by lower GFR and high microalbumin creatinine ratio. That's why it's always important for your patient in the clinic, especially if you have an internist with us today. If you have a diabetic patient with CKD, even if the CKD was not evident in the creatinine and the GFR, please do the microalbumin creatinine ratio. So what they did is involve those patients because they are a higher population with high risk that may develop into heart failure. And they did 2 trials, 2 sister trials, and 1 analysis with the Fidelity. So the first trial, if you look at the top here, is the Fidelis DKD. So basically, this is a trial that looked at what is the effect of finerenone in those population, type 2 diabetes and CKD, and the primary endpoint was a renal outcome endpoint, and the secondary endpoint was a heart failure and cardiac endpoint, and that was a positive trial. And if we look at the secondary endpoint, it was also positive toward cardiovascular protection. And if we look at the second trial, which is the Figaro DKD trial, also that trial was designed for a primary endpoint of cardiac and the secondary endpoint of renal. So they just flipped the trial with the same population. So it was a huge success and a huge effort that was done for those patient population. And also it was positive in both angles. So there was a cardiovascular risk protection and prevention of heart failure, especially new development of heart failure. And the kidney outcome also was positive in this trial. And then what they did is they did a pre-specified analysis with those 2 trials into something we call the Fidelity analysis. So basically, they pulled those data together, and we looked at it, and we still find the composite cardiovascular outcome was positive by a hazard ratio of 0.86. And the same thing, the heart failure hospitalization was reduced by almost 30%. So there was a consistent 14 to 22% reduction in cardiovascular event and heart failure hospitalization in those populations. So those populations are type 2 diabetes and CKD. They're not heart failure. So they are quote unquote stage A heart failure. So we're trying to prevent heart failure from happening. And this trial, those 3 trials showed that a strong positivity that this medication in those populations, which are high risk population, we prevented heart failure higher than the placebo. That led to the development of the next trial, which is the Fine Arts Heart Failure trial. So the Fine Arts Heart Failure trial, what they did is they looked at all the positive data that we had from the previous trial, and they designed a trial that will look primarily at the total heart failure hospitalization, worsening heart failure, and cardiovascular death. So this is a heart failure trial, basically. They looked at a patient, almost 6,000 patient, above 40% ejection fraction, NYHA 2 to 3, so stage C heart failure patient, and they started finerenone up to 40. They divided the groups into two groups. Some of them took 20, some of them took 40 based on the GFR and based on the tolerability of the patient versus placebo. So those patients with HFmrEF and HFpEF, according to the guideline managed before, we did not have except the SGLT2 inhibitor, which is probably that's why the intake of SGLT2 inhibitor was not that high in the trial, because it started while the SGLT2 inhibitor getting some evidence, but there was a good population with SGLT2 inhibitor on the fine arts heart failure. And we found that this is also a positive trial. So the worsening heart failure event was reduced, and driving the primary endpoint. The cardiovascular death also missed the cusp here, like the other medications, which seemed like the theme with the HFmrEF and HFpEF trials. And the benefit was consistent across all the ejection fraction. That's similar to the dapagliflozin and the empagliflozin. And we did not find attenuation of the benefit if we looked at subgroup that received SGLT2 inhibitor versus the group that did not receive SGLT2 inhibitor. So either you are on it or you are not on it, you still had an added benefit. If we look at the safety consideration, there was no significant, very high risk side effect, but obviously we will have some hyperkalemia because of the way those medications work by aldosterone inhibition. So you're basically retaining potassium from the renal tubules. So the potassium or the hyperkalemia above 5.5, which is moderate, was higher compared to the placebo, but we did not have high hospitalization rate or high discontinuation rate. So it was fairly acceptable result in my point of view. Hypokalemia was not that of a bigger issue, and new onset diabetes was reduced by a good percent, and there was no clear renal protection signal in this trial compared to the other previous trials, the one that was done in the not heart failure population. So what we did now, after we having all those data, obviously, like we did with the Fidelio and Figaro, we pulled all those data together. So we combined the Fine Heart trial with all the other previous data that we have, and we find at that time that it started to have the first signal of mortality benefit with Finrenone from pooled data. So the higher population you're involving in those studies, the more benefit you are getting. And if you look at some of the analysis that was done later on as some of the key subgroup, if you look at the right side of the graph here for the fine arts, you can see that ejection fraction was positive across all the ejection fraction. As I mentioned, the SGLT2 inhibitor did not attenuate the benefit. And also the same thing, there was a consistent benefit across the diabetes subgroup. So what is the clinical implication? We know now that Finrenone provide additive benefit on top of the SGLT2 inhibitor, work across the full EF spectrum, as we mentioned, 40 to 49 and above 50 and above 60, and reduce new onset diabetes. Hyperkalemia is there. It's a concern. I think we have to keep an eye on it, but it's hopefully manageable. And probably we don't have a lot of data about the potassium binders, but probably we'll gain more and more attention to once we have this medication embedded into the heart failure protocol, which is still not at this stage. The next step, what we did, or what they looked at in a smaller study, which is the confidence trial, which is a nice study. Basically what they did, they started either Finrenone alone, empagliflozin alone, or they combined both medication together. And the idea was and this is in type 2 diabetes and CKD population, so not the heart failure trial. And the idea was wanted to see, does the reduction of the microalbumin creatinine ratio will be more aggressive with combining both medication? Are there going to be any safety concerns with adding two medications? Are there going to be side effects that are unexpected? And the result was promising. So the combining both medication, the drop of the microalbumin creatinine ratio was actually almost 50% compared to the 30 and 28% when we added all medication alone. And the hyperkalemia actually was a little bit less with the combination. Probably the empagliflozin or the SGLT2 inhibitor had some protective effect. This is a theoretical data. There was no serious AKI by starting both together. There were always, as expected, some GFR decline, but that's expected probably hemodynamic, and it's usually not sustained and go back to the baseline. We don't have long-term data to see if the stability of the kidney function of both the fine arts and the confidence. Probably will have more data in the future. And the urine albumin creatinine ratio actually effectively was dropped very quickly early on the study by doing this combination therapy. So that support early and simultaneous initiation of both agent in CKD and type 2 diabetes. Now we move to the next medication that is also rising in this world. And as I mentioned, still we don't have those medication in the guideline. Our guideline is still with the SGLT2 inhibitor, but the more and more data we have, hopefully we're going to find some new guidelines and new updates, and we'll be more comfortable starting those medication and give more hope to the HFpEF population. And the medication I'm talking about is the GLP receptor agonist. So it seems to be the same theme of diabetic medication working with the heart eventually. And we're going to look at the STEP-HFpEF, the STEP-HFpEF DM program, and the Summit trial for the tirzepatide, which is a combined medication. So basically, without taking too long, the group that investigated this, what they did is they did two sister trials, the STEP-HFpEF and the STEP-HFpEF DM trial. Basically, the STEP-HFpEF was purely heart failure preserved ejection fraction trial, and the STEP-HFpEF DM was a trial with HFpEF with a diabetic population. Obesity was common in both trials, so obviously they used the higher dose. So we did not have this dose in Saudi until recently started to be in the market. We used to have only the semaglutide 0.25, 0.5 and 1, and recently we started to have the 1.7 and the 2.4, which is the one that was studied into the multiple trials that the GLP-1 showed some benefit in. And because of the smaller number of the trials, they looked at a softer endpoint, like improvement of the patient outcome in terms of the symptoms. So both trials showed the KCCQ score dropping. Both trials showed weight loss for the patient, which is good. Both trials showed improvement of the 6-minute walk test, some CRP reduction as well, which is probably beneficial. And the benefit was there regardless also of the weight loss. Like even if people who did not lose weight as much, there was a lot of benefit that was driven. So probably there is some pathophysiological mechanism behind the GLP-1 that we're going to understand later on. And I know that now there's a lot of GLP-1 trials that's going everywhere. Like they're going crazy right now. They're going with the CKD, with the liver, with the NASH or the MASH now we call it. Like a lot of trials, cancer, they're going all over the place with the GLP-1. I think we're going to see more and more data, especially there is less and less concern about the side effect profile, which I think a lot of you probably will ask about. So because they are smaller trial, what they did also, they looked at pool analysis. So they took data from the STEP-HFpEF program, from the FLOW program, which is a program that was designed for CKD, and the SELECT trial, which was a major trial that probably I should have added the slide. So SELECT trial was a major trial for CED patients, so coronary artery disease with obesity, and looked at the data together. And they looked in this pooled data at only the heart failure data, which was positive in terms of reduced heart failure hospitalization and worsening heart failure. So there was a strong signal right now that we're receiving from the GLP-1s in the heart failure population, especially if the ejection fraction above 40%. We don't have a lot of data with the ejection fraction below 40%. I think there's a lot of debate about the muscle mass. Is it true or not? I think probably we're losing muscle mass with weight loss, with every kind of weight loss. But is this more worse with the people with high HFrEF, especially they are more prone to probably cardiac cachexia? We still don't know that for sure. Personally, I'm using it in a lot of patients in my practice, and I did not see that concern. Probably I would avoid it if the patient I know they're advanced HFrEF frail patient, but a lot of other people are benefiting, especially the obese population. If we look at the Summit data, so basically this is the tirzepatide trial, so the dual GIP GLP-1 receptor that we know as Manjaro. Also, we found the same. It's a small trial also as well, but we found the same data with the positivity. It's a win ratio mechanism they use because of the smaller number of patient, with some finding of decreased pericardial fat by MRI, decreased the LV mass, higher KCCQ score. I think it's a greater weight loss with a dual receptor agonist. So probably we'll have more and more data as we go in the future. A brief mention about the iron. I'm not going to go delve into it, but a lot of the trials, when we look at the inclusion criteria, the population have some population, I think I just flipped the sign here, with a 40 to 45% range. So a lot of those population, the HFmrEF were involved in the iron studies. That's why now the guidelines said it's indicated for HFrEF and HFmrEF to improve symptoms and hospitalization. So if we look at the evolving evidence right now across the timeline, we can see that we have a negative trials area that was a little bit damping the moods, as we say. Then we have CKD foundation, starting with the MRAs, with the non-steroidal MRAs, with the SGLT2 breakthrough at the same time, almost. Now we're having more and more data with the new frontier, if I can put it, with the GLP-1, the non-steroidal MRA in the heart failure ward. And we're going to probably have the combination era later on, as we're doing with the GDMT. Still, as I mentioned, it's not in the guideline, but probably that's what a lot of people are anticipating to have in the future. So what we can, how we can interpret this clinically. So this is not a guideline. This is just a way to think about this. So we do start by tier 1, if I can put it this way, which is the class 1 medication. So the SGLT2 inhibitor, empagliflozin or dapagliflozin to all patients. There is some emerging data about sotagliflozin, still not available, I think, in Saudi, if I'm not mistaken, but probably I will be sticking with those two for this at this stage. Then we have to think about tier 2, like emerging evidence, to add the finerenone, especially in the CKD diabetic population. And we'll wait for the update to include the heart failure population. We should look at specific phenotype, the obesity HFpEF phenotype, to look at the GLP-1 tirzepatide, the combination with the dual. And if the LVF is closer to 50 and below, we should consider still the ARNI because of the data that I mentioned. Spironolactone still a class 2B in the guideline. So we do have some evidence still. It's not as strong, but for myself, probably with the newer data, I will be sticking more in the ejection fraction more than 40 with the newer medication. Obviously, always diuretics for congestion. Don't forget that. Comorbidity management, as mentioned in all the guidelines for HFpEF population. So you have to manage the AFib, the hypertension, the coronary artery disease, iron replacement for those population, the MREF population, basically, exercise, all the other non-pharmacological that we have to keep in mind. So we are shaping the future for another era that will hopefully increase the symptom relief and decrease the burden of the HFmrEF population in the future. So I can my take-home message is SGLT2 inhibitor are the only class 1 level of evidence A therapy at this stage. Start in all patients. This is across the guideline, American, European, and the Saudi guideline. Finerenone with the fine arts heart failure provide good reduction in worsening heart failure event. It could be considered later on. Hopefully, it will be added. It's not approved yet, but it should be considered as an add-on therapy to the SGLT2 inhibitor. We have a safety data from the confidence trial that we're comfortably probably can start both medication or both categories together, so non-steroidal MRAs and the SGLT2 inhibitor. The GLP-1 and the dual receptors agonist like the tirzepatide, redefining the obese phenotype. And we have a lot of data that hopefully will be promising more in the future. Don't forget the IV iron evidence, mainly in the HFrEF population and the HFmrEF. We don't have evidence strongly in the HFrEF population, so focus on that and manage your patient as vigilant as possible because those are a higher risk population, as mentioned by Dr. Ismail, high morbidity, high hospitalization, high cost in every healthcare system. And now we're having more and more tools that we can utilize. And hopefully that summary will help you with managing your patient appropriately, inshallah. Thank you very much.
Great, amazing. Thank you so much. That was really wonderful, like usual. And mashallah, honestly, you took us through the whole, journey from failure to success, from no hope to really looking to the future with multiple therapies that you can use. I mean, from just throwing diuretics to probably phenotypic approach. That's really wonderful. I'm gonna open the floor for questions. We received a few questions over the last few minutes. So I encourage the audience, if you have any question, just type it in or raise your hand and we'll give you the mic to talk. I'm gonna start with one of the audience question, probably related to the first lecture by Dr. Ismail. Can HFpEF progress over time to become HFrEF? Is this possible?
So HFpEF can progress into HFrEF in some patient population. Although it's not the typical pathway for everyone, but this usually happens when there is new myocardial injury or a new insult or ongoing remodeling, such as, for example, a new MI that takes place, uncontrolled risk factors like hypertension, myocarditis that takes place, or, for example, burnt out type of HFpEF cardiomyopathies can eventually make their way into a HFrEF.
That's amazing. Another question about using DABA and empagliflozin in patients on insulin, probably to Dr. Ibrahim, probably meaning type 1 diabetic. Would you use EMBA-DABA SGLT inhibitor in such population? I know the
Okay, that's
guidelines.
a $1 million question. So there's a lot of
Yeah.
debate about this. Um, I think there is a difference, and I would actually interested to hear your opinion, Sama, and Ismail on it as well. So if you're thinking about type 2 diabetes, it's fine. Like if you're asking about using it with a patient who's already on insulin and other oral hypoglycemic medication, that's okay. They tend not to cause hypoglycemia, so I'm more comfortable with it with the type 2 diabetic patients. They usually, I think the average drop of A1C is around 1 or 1.5, if I'm not mistaken from my memory. So sometimes if a patient like a really controlled A1C of 6 or something, usually if they are like a metformin or gliclazide, I sometimes just stop the gliclazide, the sulfonylurea, just to avoid the side effect profile and keep an eye. I'm not a diabetologist, but I keep an eye because sometimes I see some rebound with this. But it's safe to be used as a diabetic medication on diabetic population. In type 1 diabetes, there's a lot of concern about euglycemic DKA for those medication. Um, uh, Personally, I don't use it in type 1. I'm a little bit usually in the caution side of things. Usually my practice, usually I go slow, don't go there unless it's like really clear in the guideline. Although there's a lot of my colleagues from heart failure ward, they are comfortable using it as a medication for those population. For me, not that much. I usually tend to leave it in the hand of the endocrinology, especially with the type 1. Usually they are a very sensitive group of patients. So that's why I'm interested to hear your intake on it, Osama and Ismail as well.
Let's hear from Ismail, then I'll give you
Sure.
what I do.
So, the short answer is, in type 1 diabetes, SGLT2 inhibitors are generally avoided, despite having heart failure or not. And I think that, to me, is the small disclaimer that I want to go into. So, I wasn't really clear about the question. Was the question essentially a type 1 diabetes or just somebody who uses insulin? But most of our patients are insulin resistant. So in type 2 diabetes, I see no harm in using dapagliflozin or empagliflozin. But we really have to be very careful when it comes to the inclusion criteria of the DAPA-HF and the Emperor and the Liver and the Emperor. These patients had no type 1 diabetic patients. So the short answer is, to me, at least in the current time, type 1 diabetes, I would not use them. Type 2 diabetes, whether you are on insulin or not, as long as we're keeping an eye on euglycemic diabetic ketoacidosis, I would proceed.
You're muted, Ismail, but I think the message was I would use it before you were muted.
Well, was I muted for the entire
No, for the
entire
end.
response?
No, for the
Okay.
end. For the conclusion, what to do?
For the conclusion, yeah, I would use it if you're a type 2 diabetic, is what I was trying to say.
And honestly, similar to Ismail, I mean, honestly, I think I honestly I try to find the reason. Is it really true type 1 or not? I mean, and I've used it in few patients that I thought, it's the only thing that you can give this patient, especially with HFpEF. It's really tough not to give them, something that can prolong their survival. And again, as I mentioned, probably I'll carefully monitor them, make sure they don't develop. I usually educate them about symptoms of DKA and, not to take it lightly, and if they present with this, then to definitely present to emergency to make sure they're not having euglycemic decay. But I've used it. It's similar. That's probably a segue to the next question about using, patients on hemodialysis. Always, CKD patients are tough to manage, whether they are RIF or BIF or MREF. Question to both of you, probably. These medications, would you use them in patients on hemodialysis? Whether it's SGLT inhibitor, finerenone, or GLP receptor agonist? Let's start with Ibrahim.
So as the same story with the type 1 diabetes, so they are excluded from most of the major trial, from all of the major trials. There was no dialysis patient. In terms of are we gonna have some data later on? Maybe. For now, I don't usually use it. In terms of the GFR cutoff, usually that's a very common question also that we are encountering all the time. So I'm comfortable with starting it with the GFR above 20, going with the empagliflozin trial data. I know the DAPA was a little bit higher in the trials, but I think they're probably a sister medication, so I'll use it 20 and above. When the patient declining with time, I tend not to stop it unless they have an acute reduction. So for example, if the patient GFR, because we do have some data from the DELIVER trial and the DAPA-HF trial subgroup analysis that those patients with declining GFR with time usually do worse compared to the non-decliner. And when we stop the medication, the same goes for the RAS inhibition. Usually we lose some of the benefit that those medication provide. Think about it, those patients usually will drift into end-stage renal disease with time, especially the cardiorenal at the end, especially the GFRs like the 30s, lower 30s. And the SGLT2 inhibitor, if did not cause an acute event, leaving it there probably will be not causing any issues. It's not going to cause any electrolyte abnormalities. It doesn't cause hypotension or any kind of hemodynamic effect of the kidney function. And we will have some benefit by improving your heart failure symptoms and heart failure output flow probably, and that will help protecting your kidney function. But to start in dialysis, for now, the short answer is no.
Nice, Ismail.
I echo what Brahim mentioned. I think it depends on when you're starting and where you're starting from. But in the end of the day, when you've reached dialysis, things really change. I would advise at least the general population and the general physician to follow the GFR cutoffs for these medication when you're initiating. When you're outside of evidence-based terrain, I think this is the right time to make sure that you're consulting with the heart failure specialist, with a nephrologist about the risks and the benefits. But the short answer is just make sure you're abiding by the GFR cutoffs, but also the other part of the equation, even before you reach hemodialysis, just make sure why your creatinine is up to begin with, because a lot of the times it could be cardiorenal, there are other manifestations. And that's to Dr. Brahim's point. If you're on it, I would rarely take you off it unless basically something actually happened. But if you do not qualify for it, the short answer is I usually would not start it.
Beautiful. Next question about using IV iron and HFrEF. Ibrahim.
Yeah, so IV iron are beneficial in the HFrEF population. So basically in the guideline, we're using it to improve symptoms, exercise capacity and quality of life, and reducing hospitalization. We do have a lot of clinical trials. I'm not going to go over them. Most of them are with the ferrex carboxymaltose. There was another trial with the dorsimaltose. So those are the two that's mentioned clearly in the European, if I'm not mistaken. I'm now confusing the guideline, but they are the two that mentioned by name in the guideline. We're using it for patients who are meeting the criteria. So we look at the ferritin. If the ferritin is less than 100, or which is like the absolute iron deficiency, or if it's between 100 and 300 with the TSAT less than 20. So this is a functional iron deficiency population, and that's what's in the guideline right now. There was some debate about are we really getting the benefit with all people or just TSAT? Probably the functional are the group with the greatest benefit, but I think let's stick with the guideline at this stage. So it's always important to check your population. I do it every 6 months with the ferritin and TSAT just to see if your patient fit into those population. Most of the trials, the hemoglobin was less than around 14, 14 and a half. So if your hemoglobin above that, I'm not sure if there is a lot of benefits. So usually I do the CBC and the ferritin and the TSAT. And if it's low, we usually give the IV iron because we know that the oral iron in those population does not work and does not do any benefit, just side effects. Obviously, you have to look into the anemia first. Like if the patient was okay for a long time, like I know theoretically, most likely those patients having iron deficiency anemia because of the chronic disease status, etc., etc. A lot of the reasons, but you need to make sure they're not bleeding, they're not they're investigated by GI, doesn't need scopes, etc. before you replace your IV iron in those population. And the ejection fraction in the mid range also benefit from this IV iron.
Beautiful. Question very practical from Professor Faz Shah. For Dr. Ismail, what's your approach to distinguish HFpEF from the mimickers of HFpEF?
So I think in the end of the day, this is why we're starting to see shortness of breath clinics starting all over the world. And these shortness of breath clinics are a combination of multidisciplinaries. But really, the basis of this is an algorithm. But even before the algorithm, the basis is to make sure that you have a diagnosis. So you need to apply the universal definition. You make sure that you have a diagnosis of heart failure, and then basically start investigating. So pick the algorithm of your choice, so to speak, but make sure in the end of the day, before you quote unquote stick the label of HFpEF on your patient, I went through these 17 diagnoses. So for example, my patient doesn't have renal disease, my patient doesn't have amyloid, doesn't have valvular disease that could explain this, doesn't have pulmonary hypertension, etc. And I think either an up-down or a down-up approach in a HFpEF is usually the best way to go before you stick this label, because I can tell you, once this label is stick, it's going to continue with your patient for the remainder of your life. You see these charts and you see these codes on your patients. And a lot of the time, I find it difficult to delabel a patient when it's much easier to label them. So I would caution everybody to make sure that we apply some sort of algorithm.
Very nice, beautiful. 300%. Another question, again, probably this summarized what Dr. Ibrahim was mentioning. How do you see the future of HFpEF management evolving from precision medicine and biomarker-guided therapies? Very practical. What do you think, Dr. Ibrahim?
Yeah, so I think you can see from Dr. Ismail lecture that he's mentioning the phenotypic grouping of the patient, because those population, I think the lesson we got from the previous failures of those population, that we applied like the same medication with the HFrEF blindly and would not specify them into a phenogroup because they are different. So we need a lot of data to drive this. So now there is a lot of discussion about moving beyond the classification, and the people with HFpEF, you can divide them into the group with the obese cardiometabolic, where they're going to have higher BMIs, lower inflammation, higher GLP-1 use usually will be beneficial. The cardiorenal RV failure population probably with the higher nitritic peptide, worsening kidney function, high incidence of AFib. With the non-steroidal MRAs, probably the inflammatory fibrotic type as well, with the inflammation is driving the disease. We still don't have an anti-inflammatory medication that's successful. There's an ongoing trials with the interleukin-6. We had previous failures in before with the heart failure ward, the anti-inflammatory, probably theoretically because they tend to have a lot of side effect also. And now with the interleukin-6, maybe will be more selective down the line at the end cascade of the inflammation. We still don't have the data. I think we're going to have some data next year, if I'm not mistaken, for the heart failure population. So that's probably where we're heading. It's an evolving field, and your patients will be benefiting from all the newer medication that we are discussing today.
Yeah, Dr. Ismail, anything to add?
I agree with Dr. Ibrahim.
Yeah. So I have a question to both of you. Steroidal, non-steroidal MRA. Why TOPCAT failed, and now actually more recently the Spirit HF trial also failed for spironolactone. although with the limitation of the SPIRIT-HF, they failed to recruit enough number of patients because of COVID. But again, spironolactone give a neutral effect or maybe more harmful with hyperkalemia in patients with mildly reduced and preserved compared to fine arts and fine arts with, clearly meaningful results using a non-steroidal MRI. Do you think the key is about steroidal, non-steroidal? Let's hear from Rahim, then Ismail.
Yeah, so I think probably that's the reason. So there is distinct molecular structure difference between them, with the non-steroidal MRA being more balanced cardiorenal distribution, if I can put it this way. The steroidal MRA maybe have off-target effect, if I can put it this way, with higher side effect profile. So maybe that's one of the reasons. Balanced tissue distribution, side effect profile may be higher a little bit with the steroidal MRAs, and we should just go with the data. Like, we have now positive data, so that will re-emphasize the theory behind it. And now I did not actually look at the spironolactone recent data. I'm not sure if Ismail looked at it or not. I heard that it was a negative trial, but I don't know the details of it. But that will probably, it was a disappointment for a lot of people who believed in the Top Cat trial, probably and I was one of them actually. But maybe it's true. Maybe the development of this, the molecular evolution that we're facing right now is driving the benefit rather than the old molecule that we're using.
Dr. Ismail.
So I'll answer the last comment first. I believe you're talking about the SPIRIT HF trial. So it was published in the ACC recently, and essentially they looked into heart failure with mildly reduced and heart failure with preserved ejection fraction. And they took NYHA class 2 to NYHA class 4, and they used 25 and 50, depending on your potassium and your renal profile. And the primary endpoint, as we've seen in all our heart failure trials, were hospitalization and CV death. And the short answer is there was no difference. So it's a bit underwhelming, so to speak, but it also tells you about what is happening, because we kept extrapolating. And, we've talked about this before, about taking the American data out from the European data. But one of the things that is really interesting is, where is the future heading? And I think this really falls on this upstream and downstream effect that we're getting with these new non-steroidal MRAs. Because at the end of the day, a spironolactone is just blocking the receptor, but you still have all this aldactone or this MRA circulating in your body. So there is some evidence that tells you that these non-steroidal MRAs have anti-inflammatory properties and anti-fibrotic properties that affects both your kidney and your heart. And the short answer, and I think that might be the key factor that we're missing, but we definitely need more data, need more research to tell us where we are. But at least from where we stand right now, based on the available data that we have, it seems very promising.
Yeah, amazing answer. And I think more medication in the pipeline. So now we do have, more medication for non-steroidal to prove. Also, there is the ongoing SPIRIT with double R trial that testing still aldactone, spironolactone. So hopefully we'll get more answer than, the downside about the SPIRIT-HF, the problem what happened during COVID, and there was, they were planning 1,400 patients and recruited half of the patients, so only 700 patients. So it really underpowered to detect the difference. So I don't think we can draw a conclusion about, is it the end of spironolactone? Probably not. Although, as Ismail mentioned, you do have new medication nowadays, non-steroidal Ferinon, very active, positive trial. So I don't know. I think wait and see is the right answer about spironolactone. Dr. Khuldoon posted a question, very interesting, very practical like usual. A 60 female with lower limb edema, limited mobility, unclear dyspnea on exertion, obese, BMI of 40, hypertension for 20 years, ejection fraction 60, E over E prime 8.8, septum is 1.3, mild LA enlargement 4.3, RBSP 30, IVC is normal, proBNP is 420 for this obese female. No other causes of edema. normal renal function, UCR albumin is 40. Classic presentation for typical Saudi, Kuwaiti, Gulfi patient. This is a patient with maybe bending filling pressure, labeled as HFpEF. So I started this GLP inhibitor because of A1C was 5.8 and would repeat the proBNP again and reassess the natriuretic peptide and the edema. How would you approach this patient? Classic typical patient. Okay, so I see Ismail is very want to jump on this.
Sure. So, the issue is here is this is not uncommon. And, we see these patients a lot. So she has strong risk factors, as you've seen. There is obesity, long-standing hypertension, possible exercise intolerance. But, the resting echo is not clearly diagnostic. The E over A is within normal range. RSV is normal. ISV is normal, but there's also mild LA enlargement. And the proBNP is 420. This actually might be meaningful because in obesity, as we mentioned, the BNP is actually lower. So I think there are three main approaches I would have to such a case. So I would treat the congestion pragmatically if clinically present. That would be the first step. And then I would continue risk factor modification because there's a lot that we can do here. Weight loss, blood pressure, exercise, sleep apnea, screening, for example. And I would assess her symptoms after the SGLT2 inhibitor. But at that point, if I've done these three things and I'm still uncertain, that would be when I would pull the plug on exercise diastology testing. Or even more further, I might consider invasive testing.
Very nice answer. Yeah, Ibrahim, I know. Very
Yeah, so
common.
I might add my echo hat right now. So I think and I'm thinking Sam برضه you agree with me that there is a big problem with the diastolic
Yeah,
definition on echocardiography.
agree 100%.
And the 2016 guideline did not make it easier. There's a lot of uncertainties, a lot of confusion. And I think now I invite everyone to look at the 2025 guideline, which is actually make it a little bit simpler. So now there's more reliance on the tissue Doppler by itself. So the E wave, the E prime by itself as a number because it's correlated with the LV relaxation. So you don't need to have all the parameters before. So if you have only the septal is below 6 or the lateral below 7 or the average below 6.5, you're already there. Like you're already moving to the next step in terms of the diastolic dysfunction assessment. There is now more parameters into the echo. So I know the EE prime is considered as well a TR velocity, but they are not the only issue. So you have to have all of them normal to call your patient normal LA pressure. If you have only the reduced E prime by itself, then you are automatically assessing the patient. It's automatically grade 1 or higher. And they're now having more parameter to look into the pulmonary veins, the LA strain, which is not still readily available in all the labs, I think, the relaxation time. So I think the emphasis is we're going to catch more people with this criteria. And if and looking into only the EE prime from before probably is less sensitive, if I can put it this way, in catching those populations, especially the population that Khaldun is mentioning. So I think that's just be aware of the new updated guideline. Be aware of the false negatives of the premium B with the obesity and everything else. But and usually when you have a mild delayed dilatation, this is just something that scream high pressure for you because why your LA gonna be dilated if you don't have like an MS or something else going on because your LV in diastolic pressure is high, so you're trying to compensate. Even if you're not catching it with the other parameter, your LA will dilate because of this. Unless, obviously, if there's AFib, it's going to confuse the picture a little bit, but for us, this is one of the things that usually make me think more that this patient, probably I'm happy with the diagnosis, especially if, as Ismail mentioned, if they're behaving like heart failure, walking like heart failure, it is probably heart failure. And that's my two sentences about it.
Very nice, but very elegant answer, both of you, to be honest. And I want to again emphasize the same thing you mentioned, Ibrahim. The LA, I mean, usually the answer is there, especially like when you see a young patient with dilated LA, there is something. I've detected a lot of like inherited cardiomyopathy because the LA was dilated and the myocardium didn't look like normal. So you really, as you mentioned, there is something wrong. The filling pressure is high. The fact that, as Ismail mentioned, the protein B is normal for an obese patient doesn't exclude heart failure. The fact, the EE over prime is normal, as Ibrahim mentioned, doesn't exclude heart failure because they are resting. Maybe she's, fasting because you told her to come for labs today, and that's why her AA pressures are normal. A over A prime is normal. So again, this have I done a stress test as Ismail mentioned? Probably not, because sometimes I can detect these patients and label them as HFpEF even without. Again, you don't really have to follow the scores 100%. If it's as Ismail mentioned, if it feels like HFpEF, it's HFpEF. Like this patient, mildly elevated protein B, she has all the risk factor to be HFpEF. I would treat her. And again, as probably Dr. Khaldoon mentioned, SGLT inhibitor is not a bad idea in this pre-diabetic patient. How about GLP receptor agonist?
Yeah,
I
I
mean, her
think
BMI is 40. I mean, she
how
has
about
class 1 indication for
exactly.
regardless of her HFpEF or not, she will benefit from, probably, GLP receptor agonist. Then maybe, how about aldactone in this patient? Would you consider it? I mean, if you don't believe she's HFpEF or you think she's HFpEF, I mean, just to give advice for Khaldun, would you like
Yeah,
he's doing the right thing. SGLT inhibitor done. Everyone agrees that, she
yeah,
needs to be on SGLT
for
inhibitor.
me, if I believe it's a HFmrEF, HFpEF, I have the data to support my claim about the Fendrinone. Still, as I said, it's not the guideline yet, but I'm more comfortable right now using in those patients with a good relief of symptoms, to be honest. And as you mentioned, GLP-1 will be beneficial for weight loss. That will help also as well. Um, repeating the urine album creatinine ratio every now and then. She's heading there in terms of the diabetes. She's already pre-diabetic, so I think what he did with the SGLT inhibitor was excellent. And I agree with his point. Like usually, probably it's one of the most common dismissed population, this kind of gray area, people with dyspnea on exertion, a little bit obese. So automatically the physician will blame the obesity and the lack of exercise and stamina to this and just ignore everything else. And obviously, if the echo is read by non-echocardiographer, poor quality, a lot of the hospital, they're doing the bedside with no documentation. They don't measure the E prime. So uh, we're probably missing a lot of those patients.
Yeah, I can't agree more. And he just added the points, he doesn't want that's because I agree. I mean, the attendee probably, big part of them, again, as you mentioned, probably they will misdiagnose these patients as deconditioning obesity. So I think Khaldun really raised this issue in the question and answer box that, treating her early with a GLP inhibitor was a great thing to do, probably. Okay, so we have 3 minutes. I'm gonna finish with this question, probably outside this talk, but he's interested to know, is EAC certified cardio-oncologist? I want to ask about presence of cardio-oncology center in Saudi Arabia. Anyone knows if we have cancer, where cancer patients are treated? I
We
mean,
have the
probably
two
this is,
cardiologists in
I
Saudi
know.
Arabia on
So
the same panel.
probably, yeah. So for Ismail, we'll leave this for Ismail.
I think the big picture is yes, it's a growing field. There are growing interest, and every oncological center has, let's say, access to a cardio-oncologist, at least for now, until we grow and we add more numbers. But just push us an email, and we'll be more than happy to collaborate together. Dr. Osama and I work in the same center in Riyadh, and we'll be more than happy to assist you however you need.
Perfect. That's a very nice. And so at the end of this webinar, I personally, I really enjoyed it. It was really full of, from basics to advance, from, failure to success. And again, in the pipeline, a lot of things happening for these patients. I really want to take this opportunity to thank the attendee for sticking in this evening. And mashallah, we reached a huge number of attendee, full room of mashallah. People who really attended so early to guarantee their slot. And I really want to thank the elite speaker, Dr. Ibrahim Jalidan, Dr. Ismail Raslan, for really fantastic lectures. And thanks for Bayer for sponsoring this webinar. And inshallah, more to come. in the future. Again, CME hours, if you register, you will receive them inshallah in a few days. And this lecture is recorded and will be uploaded at the link provided. At the end of the evening, I wish you a great, safe evening and enjoy the rain if you are in Riyadh. If you are in Jeddah, good luck. بالتوفيق للجميع إن شاء الله.
يعطيكم
شكرا
العافية.
جزيلا، يعطيكم العافية.
أجمعين يا رب. Thanks.